Hi guys, my name is Ulus Christopher Bobai. I'm a final year student of Bio University Kano. Today I'll be enlightening us on a very important topic that affects most women around the world. The topic is uterine fibroid. Uterine fibroid, also known as neomyoma or fibromyoma, is a common condition that usually affects women of reproductive age. Reproductive age women usually from the age of 15 to 49 years of age. Now, what is uterine fibroid? By way of definition, uterine fibroid is a benign tumor in the sense that it's not malignant, meaning it's just a growth that the woman can still be doing her daily activities, but it's not malignant. Then it usually affects the uterus, otherwise known as the womb. So it affects the smooth muscles, and also the connective tissues. So in the uterus, there is what we call the smooth muscles, that is the muscular layer of the uterus. That is where this condition usually affects. You understand? So now there are some risk factors that predisposes, that if these factors are there, it makes these women liable to get this condition. So the number one risk factor, let's look at risk factors. So the number one risk factors here we say is nulliparity. So now what is nulliparity? Nulliparity means when a woman has not conceived at all. She has not bear any child in her life. You understand? That is nulliparity. You understand? Or she has given birth, maybe she gave birth to one or two, then it takes her over a long period of time to give birth to another child. So now, during that, when a woman has not given birth, normally there's a saying that goes that if a woman has not given birth, either the womb or the uterus usually harbors fibroid or it harbors a child. So you must get one of it. Even if you don't want to give birth, you will have fibroid. Most ladies have fibroid without them knowing even. So nulliparity plays an important role in uterine fibroid. And also, two, we have early menarche and late menopause. Now, this fibroid depends on estrogens, you understand? So there is estrogens. When females start menstruating, there will be high level of estrogens. So this fibroid now, they are estrogen dependent. They like estrogens. So when a lady starts her menstruation early, that's what is called early menarche. That is from the age of, let's say, as early as 8 or 9. So they tend to have fibroid because there will be elevation of estrogen at this stage. And this fibroid likes estrogen. It depends on estrogen to survive. And also late menopause, you understand, because of the long duration of menstruation. When menstruation stops, it's called menopause, meaning the estrogen levels will drop. But if there's late menopause, meaning this estrogen will keep producing up to, some women can even menstruate up to the age of 55. So they stand a risk of having fibroid, uterine fibroid. So we have another one called the obesity. Obesity also plays a role in uterine fibroid because when a woman is obese, there's also a high level of estrogen. And like we said earlier, fibroid depends on estrogen to survive. So now we'll look at some. So these are the very few. Risk factors that predispose these women to uterine fibroid. So now we'll look at the protective factors that would prevent these women from having uterine fibroid. So we have the protective The number one protective factor, since we say nulliparity is the risk factors that makes this woman develop fibroid. So what is the protective factor? It's when you want, it's when the woman gives birth. So multiparity, the woman that is having children, has a slim chance of developing uterine fibroid. Also, we have smoking. Science have proven that smoking actually prevents uterine fibroid. But that doesn't mean you should smoke, because smoking has an anti-oestrogenic activity. That means it inhibits estrogen, which helps the fibroid to grow. But that doesn't mean that you should smoke. Smoking is bad. It's not good. So we have seen the protective factors. Now let's go to the types of uterine fibroid. Now, the types of uterine fibroid, there are different types of uterine fibroid. So now, this is the uterus. This is the woman uterus, otherwise known as the womb. So there are different types of fibroid on different parts of this uterus now. So this inner part of the uterus is called the what? It's called the endometrium. And there is a fibroid that usually develops. It's the most commonest, actually. It's the most common type of fibroid that develops here. And the fibroid that develops here is called the submucous. The submucous type of fibroid. Then we have another fibroid that can develop inside the smooth muscles. You know, from our definition, we say that it affects smooth muscles and the connective tissues of the uterus. So there are some type of fibroid that develop inside the smooth muscles, and we call this one the intramural type of fibroid. Then there's another type of fibroid that develops at the perimetrium. That is this outer layer of the uterus. It is called the perimetrium. And another fibroid develops from here, which is called the subserosa. The subserosa types of fibroid. Now, this fibroid, when they develop in these parts of the perimetrium, that is the subserosa fibroid, sometimes it can grow to the point it can dislodge. And when it dislodges, there's a structure here known as the what? This structure is known as the broad ligament. Now, it can dislodge and get into the what? Into the broad ligament. And it now becomes the broad ligament type of fibroid. And sometimes this fibroid can even leave the broad ligament and enter into the what? Into the cavity and becomes the wandering or the parasitic fibroid. And also, this submucous type of fibroid, it can grow to the point where it will develop a stalk. It's still attached to the endometrium, but it develops a stalk. So it will become something like this. Meaning it's not completely out, but it's still stuck to the endometrium. So this type of fibroid is called the submucosa pedunculated type of fibroid. Meaning there's a peduncle, that's a stalk. That is the meaning of pedunculated. It has a stalk. So sometimes it can dislodge even. It can dislodge and enter into this structure here. This structure here is called our cervix. So it can dislodge and enter into the cervix and becomes what? Becomes the cervical fibroid. And again, this subserosa also can also form a stop outside before entering into the what? Into the broad ligament. So just like how this one is called submucosa pediculated, this one is also called, now this place is our what? Sub what? We say it's our what? Subserosa here. So it can become what? It can become the what? The subserosa pedunculated type of fibroid. So now, having talked about the types of fibroid, let's talk about the clinical features of fibroid. So the number one clinical features of fibroid is we have what we call the menorrhagia. The menorrhagia just simply means heavy menstrual bleeding. Heavy menstrual bleeding. So if you are a woman and you experience heavy bleeding than your usual type of bleeding, then you must have a risk or a chance of having what? Uterine fibroid. So anytime you develop heavy menstrual bleeding more than your usual type, please see a doctor so that you undergo proper screening. Then we have abdominal pain. So the patients with uterine fibroid usually have what? Abdominal pain. Because why? Because sometimes this peduncle can twist. So when they twist, as they twist, they become painful. So it's part of the clinical presentation of uterine fibroid. And also, we have abdominal swelling. You see sometimes you're having swelling more than usual. So if you see any swelling on your abdomen, that's your stomach, and it is painful, and you're having heavy menstrual bleeding, please see a doctor. It might be uterine fibroid. So now, let's talk about the pathophysiology. Pathophysiology is how the menstrual bleeding, and I've talked about how the pain and the swelling occur. So now let's talk about how the heavy menstrual bleeding usually occurs. So now, this fibroid, now when it starts growing here, it increases the surface area of the uterus. So when it increases the surface area of the uterus, increasing the surface area means it stretches the uterus more than the normal size. So when it increases the surface area of the uterus, it makes blood flow to it increases blood flow to the uterus, and that is why they usually come down with heavy menstrual bleeding. Increase in surface area increases blood flow. So the number one reason why they come down with heavy menstrual bleeding is that there is increase in the surface area of the uterus due to the presence of the fibroid that is here. And also there's an imbalance to thrombosin and prostaglandins. So there's an imbalance. When there's an imbalance of the thrombosin and prostaglandins. Prostaglandins is a vasodilator, while thrombosin is a vasoconstrictor. So when there's an increase in prostaglandins than thrombosin, there will be what? There will be it's prostacyclins. So there will be what? There will be heavy bleeding. Because now this prostacyclins is a vasodilator. So now, quickly, let's talk about the treatment of uterine fibroid. So the treatment, we have conservative management. The number one conservative management we want to do is to give them antifibrinolytics to stop the bleeding. So number one, we give what? Antifibrinolytics. E.g., example of antifibrinolytic is the tranexamic acid to stop bleeding. Then the number 2 thing you want to know, I told you that they have pain. So we want to relieve them from the pain. So we give them analgesics. So our analgesic we want to what? To give. We can give our what? NSAIDs, non-steroidal anti-inflammatory drugs, e.g. our ibuprofen. That is, if the patient is not asthmatic. If the patient is asthmatic, we cannot give them NSAIDs, we give them other types of analgesia. Then we'll come to we can do the relative type of treatment, that is the medical type of treatment and the surgical type of treatment. Now let's quickly talk about the medical treatment. We can give some drugs, like number 1, we have the danazol. The danazol, what danazol does is that these androgens, some androgens are converted to estrogen. And I told you that fibroid likes estrogen. So now, there's an enzyme that converts these drugs. It's called the aromatase enzyme. So this danazol, what the danazol does is that it inhibits these enzymes. Then there will not be conversion of androgens to estrogens. Then the fibroid will not be able to survive because there is no estrogens that usually boosts its growth. Then we can give what? Our progestins. Then we can give our, there's what we call gonadotropin releasing hormone agonist or the antagonist. Because of time, we're not able to explain much, but these are just the few drugs we can give. Then for the surgery, we have 2 types of surgery. Number 1, we have the myomectomy, and number 2, we have the complete hysterectomy. Now, when the woman has given birth complete, like that she has completed her childbearing stage, we can just remove the uterus since she don't need the uterus any longer. But when she has not given birth, we can't remove her uterus. You understand? We cannot remove her uterus because she will likely give birth in the future. So we just do myomectomy. Myomectomy is for women that are still going to give birth later in life. So we just remove the fibroid and we preserve the uterus. But when a woman has finished giving birth and she decided that she don't want the uterus any longer, we can remove the uterus completely. So this is just a summary on uterine fibroid. So more videos will be released for more topics. Please follow, like, and share. See you next time. Bye-bye.